Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I'd like to thank the Society and the organizing committee for this invitation today. Also, I'd like to thank all of the attendees who came here, even if it is the last day of the conference, to listen to what I have to say. Hopefully, it will live up to the expectations. The topic today will be about the guidelines and management of ANCA-associated vasculitis and what is new in the field. Of course, it's a field that we used to have more questions than answers. Thankfully, recently, we are receiving more and more answers of these questions, and I've chosen 3 of these questions to be discussed today in our talk. There are a lot of material that are not covered in general because it's a huge topic. I'll be happy to be here during the Q&A session and also afterwards to answer any questions that we have not spoke about. So this is the outline. So we'll start with an overview and general principles. The 3 questions, the first one will be how much steroids is really needed in induction and also in maintenance, and are there any alternatives? The second question would be what is the role of rituximab? And the third, what is the role of plasma exchange? And then we'll finish up with a summary of what we have spoken about. So this is the flag of vasculitis, still stratified, large, medium, and small, immune complex and none, and we'll be focusing on this box here in microscopic polyangiitis and granulomatosis with polyangiitis. In general, while addressing or reading any paper that is published, we need to keep in mind it is very difficult to get a homogeneous cohort, so it is very heterogeneous in getting the patients in any study that we read due to the rarity of the disease and also due to the many ways that the patients with GPA presents. Second, it is still believed that PR3 positive ANCA-associated vasculitis are more relapses and they have more severe disease, but luckily they respond better to treatment. Third, that patients, whenever we encounter a patient with GPA with a new symptom, always keep in mind the question, is it something that is chronic and we need to accept as a new baseline or something new indicating a new relapse? For example, the stable proteinuria and the peripheral neuropathy we always have with patients with small vessel vasculitis. A very important category of patients we need to recognize while encountering patients with vasculitis are these patients presenting with severe life-threatening diseases, either CNS, lung, or any system. Continuing on the principles of managing patients, usually the induction phase is up to 6 months and the maintenance phase is up to 2 years. But again, is 2 years enough or not? Multiple studies have came out with suggestions and hinting how much do we need. One of them was published in 2017 when they took 117 patients who were induced with cyclophosphamide and then maintained with azathioprine and prednisone. On the 2-year mark, they were stratified either to continue or to stop the maintenance treatment. Of course, when they continued for another 2 years, up to 4 years of maintenance, it resulted in less relapses. So again, is 2 years enough? Is 4 years enough? Or maybe we need to go beyond 4 years and continue. So now going to our first question, how much steroid is needed and are there any alternatives in the market? So what we are used to is to give for severe life-threatening disease 1 milligram for 3 days, followed by 1 gram IV for 3 days, followed by 1 milligram per kg per day, aiming to taper 0.5 at the 3rd month. A lot of studies had addressed this question. The most recent was the Pexivast trial, the very well-known Pexivast trial, which was published in 2020, where they addressed the need of prednisone and plasma exchange in severe life-threatening disease. We'll come to the plasma exchange part when we talk about it, but regarding the prednisone, they compared the standard, which we mentioned on the left upper corner, and they compared it with another protocol, which is a reduced dose. And they found that it was non-inferior. So the reduced dose was quite non-inferior to what we are used to giving the patients in terms of the primary outcome, which were death and end-stage kidney disease. A Japanese group published in 2021 their findings when they took 140 patients patients with having non-severe GN or alveolar hemorrhage, and they stratified them and randomized them to either low dose steroids, which is 0.5 milligram per kg, aiming for 0 at 6 months, or 1 milligram per kg, aiming at 10 milligram per day at 6 months. So the primary endpoint was the number of relapses and BVAS, and the reduced dose was non-inferior, again, to the standard what we're used to. So two studies with good number of patients suggested that we don't need that much of steroids that we're used to give. Currently, the TAPER study, which is highly anticipated to publish their study results at the end of the year, where patients who are in remission, they were randomized either to stop at 6 months or continue for another 6 months. So the finding would be very interesting. Another study with the same concept, either to continue after inducing remission or continue prednisone or stop, and this is expected to publish their finding next year in 2024. As for non-severe disease, it can be used alone as a first line, but more than half of the patients will require additional DMARD. So it is advised to start methotrexate or Imuran at the start just to reduce the toxicity of prednisone in treating these patients. So other alternative, the new kid in the block is avacopan. Avacopan is a C5a receptor inhibitor, and the classic trial in 2020 was aiming to show that there is no safety signals in treating patients with avacopan. But prior to that, the first study, the CLEAR study in 2017, which was the first randomized controlled trial to see if the patients will benefit from avacopan and alternating with the prednisone. And avacopan was shown to replace prednisone without compromising efficacy. The most recent and the most significant is the ADVOCATE trial in 2021, where avacopan was shown to be non-inferior, but not superior at week 26, but it was superior at week 25 and in week 52 in maintaining remission, and with a signal of benefit on patients with kidney disease, and of course infections was much less with people taking prednisone. Moving to the second question, what is the role of rituximab? Rituximab is still believed and it recommended over cyclophosphamide in remission induction. And this belief started in 2020 with the RAVE and rituximab trial, when it was compared to the standard of care back then, which is cyclophosphamide, and it was non-inferior to cyclophosphamide, of course, with less toxicity that comes with cyclophosphamide in terms of neutropenia, bladder injury, and malignancy. Currently, the Endurance trial is trying a new approach, low-dose cyclophosphamide with rituximab in induction, aiming to reduce the toxicity of both rituximab and cyclophosphamide. The Meritxin trial, which was published in 2014, showed that rituximab was much more beneficial in keeping the patient in flare-free remission. And the rate of relapses was 5% in the rituximab group compared to 28% in the azathioprine group. And they published their finding also at month 60, and it showed the same results. Meritxin 2 compared tailored to fixed rituximab in terms of maintenance, and there was absolutely no difference. Meritxin 3 randomized the patient in Meritxin 2 after 28 months to either continue rituximab for another 4 doses 6 months apart, which comes to 2 years, or stop them. Of course, if you continue rituximab, you'll definitely achieve lower relapse rate. Similar to the first Meritxin trial, the Rituximab trial included 188 patients who were induced with rituximab, and then they were randomized to either receive rituximab 1 gram Q4 month or azathioprine 2 milligram per kg. And similar to the Meritxin, rituximab was superior to azathioprine. This was published and the ACR 19 as an abstract, still awaiting the final report of the trial. But what is the price that we pay for giving such much rituximab? So a study included 142 patients in the rheumatology, including lupus and ANCA-associated vasculitis, but more than 100 patients of them were ANCA-associated vasculitis, so that there's significant hypogammaglobulinemia and secondary immune deficiency. And the risk factor to have this is prior immune suppression to rituximab and prolonged glucocorticoid and female gender. Of course, giving IVIG randomly, just according to the level, did not show any benefits, but when it was given to patients with severe infections, the rate of recovery from the infection was much higher. Going to our final and third question, what is the role of plasma exchange? So we go back to the PEXIVAS trial. So patients who received plasma exchange showed that did not reduce the incidence of primary endpoint, either end-stage kidney disease or death, nor the secondary endpoint, which is sustained remission and serious infections. So there was a recommendation against using plasma exchange. And this was published in 2020. But going back in time to 2007, the MEPEX trial suggested that we should use 7 plasma exchange in addition to the standard of care, but they can only prove its benefit up to 12 months follow-up, and the four-year follow-up was really, they could not prove that it was beneficial, and it was unclear. So we see the contrast between MEPEX and PEXIVAS trial. There are a lot of factors that might lead to this. So in this 13 years gap, there was an improvement in diagnostic, and rituximab plays a major role, and also the supportive care. And that's why we see that the added value back in 2007 was more than when it was published in the PEXIVAS trial in 2020. So in general, plasma exchange is recommended for patients with higher risk of progression to end-stage kidney disease, recommended for anti-GPM disease, and not recommended for patients with pulmonary hemorrhage. So worth mentioning, again, a lot of trials and new medication trying to be introduced into the guidelines. So belimumab, first it was studied in the PREVAS study, and it was added to azathioprine and prednisone, but it did not reduce the risk of relapse. Currently, the COMBIVAS trial, which is recruiting mainly in France and Europe, trying to add belimumab to the standard of care of rituximab in maintenance to see does it continue to have a relapse-free maintenance. Abatacept is currently being studied as an added treatment to methotrexate, azathioprine, or mycophenolate, try to achieve sustained prednisone-free remission. A new CD20, which is used in hematological malignancies, was used in a case series in Cleveland with patients with severe relapsing disease and patients who have severe reaction to rituximab, and it showed very beneficial response. But of course, this is just a case series of 3 patients, and we expect down the road, probably in 5 to 10 years, for this to be studied in ANCA-associated vasculitis. So in summary, some insights that less is more. Can we say that about prednisone, cyclophosphamide, plasma exchange, and IVIG? More is better in terms of maintenance. So all studies showed that more is better in terms of maintenance, but the question still remains, rituximab 500 versus 1 gram, and the interval, is it 4 months or 6 months? Methotrexate and azathioprine, how much do we need it for how long? So as I mentioned at the beginning of the talk, a lot of questions waiting for some answers. We're getting answers year by year, hopefully to build a clearer picture. This is my last slide. So stratifying patients with severe or non-severe disease. For severe disease, GPA or MPA induction, still rituximab and prednisone are the mainstay of treatment, followed by cyclophosphamide. Plasma exchange and IVIG might be used. As for maintenance, rituximab is taking a bigger role in addition to prednisone. Azathioprine, methotrexate as maintenance as well can still be mentioned and used, and to a lesser extent, leflunomide and mycophenolate. As for non-severe disease, methotrexate and prednisone in induction, azathioprine also can be used, leflunomide and mycophenolate to a lesser extent. For non-severe disease maintenance, methotrexate and azathioprine, to a lesser extent steroids, and we try to keep them off steroids after 6 months, and also leflunomide and mycophenolate can be used in a very small segment of patients. By that, I conclude. I would like to thank you everyone for listening and attending.